We're going to go on to questions now. And so Dr. Dodick, I hope you're still online. Yes, you are. We have questions actually for all three of us. Dr. Dodick, you certainly raised a lot of interest with your discussion of omega-3s and 6s, as you might have anticipated. We have a question that if omega-6s aren't so good for pain, then why do we have all these combination preparations of omegas 3, 6s, and 9s? And in addition, the question was, are omega-6s helpful for heart health? And is that a problem then for people with migraine?
Yeah, so we really haven't been discussing omega-3s or omega-6s when it comes to migraine prevention until right now. I don't know about you, Dr. Becker, but I don't ever remember this being a topic of discussion at any national, domestic, or international meeting of migraine. But this study really shined a light and is educating all of us on, the metabolic pathways for these omega-3s and omega-6s, and why do some of these combination supplements contain omega-3s, 6s, and 9s? Well, perhaps for migraine pain, that's not good. And so taking omega-3s like EPA and DHA, where EPA really is good for heart health, at least the abundance of evidence would suggest that it's good for heart health, despite some recent conflicting evidence. And DHA, which is the fat that's contained in our brains, right? It accounts for 90% of the fat in our brains, is good for brain health. So if I were to increase the amount of omega-3s or omega-6s in my diet, based on what we know about how these different omega-3s and 6s are metabolized, based on how the metabolites, these oxylipins that come from the metabolism of omega-6s, actually sensitize pain fibers, I would definitely say that according to that science and according to this study, I would definitely decrease omega-6s and increase omega-3s. And that is good for both your heart and your brain, I think.
Thank you. We have a question that perhaps involves two of the presenters. I'll just start with Kara, and that is, the question is, what research is being done to explore the impact of systemic trauma or in the medical system? For example, dismissive comments and misdiagnosis and even abuse on things like migraine. So a question about the medical system and how it's currently functioning.
Such a great and important question that I don't know that I have enough knowledge to answer exactly the way the question was asked. I'm not sure kind of what current research more broadly is going on related to the kind of systematic impacts of how the healthcare system treats and the impact on migraine. I can tell you that I've been fortunate to be involved in a lot of work within Alberta Health Services to provide specific training on trauma-informed care, advanced relationship skills, kind of managing bias and unconscious bias. And I was really, really impressed with the uptake of these. So I started with sort of 2 sites, and I guess word got around, and for probably a year, like twice a week, I was presenting to sites on this and getting more follow-up research and coming into booster sessions. So that was something that I was like pleasantly surprised with in terms of the uptake and the interest. And I like to believe, and maybe this is naive, that sometimes healthcare providers and health systems go about doing things the wrong way, which we need to recognize and address. But it's often not coming from somewhere intentionally malicious. And that if people know better and have a different set of skills that they can practice and get feedback about, then they're going to do better. And then I'm also involved in some PhD research where we're designing with patients and providers. So it's a co-design where the people directly impacted by it get to design their own chronic disease management program, which is highly focused on pain and those pains that we can't measure that well, like migraine pain, so that the interventions are based on kind of best science and best research, but also have a voice from patients and from providers and fit that actual context and the nuances within that context, which I'm really excited about and I think holds a lot of promise. So I apologize, I can't answer your question exactly the way you asked it, but those are some of my thoughts that come from your question.
Well, thank you. Thank you. And so, Kara, you mentioned the words that are so important to patients. I believe you. And I think we have Cassandra online still. Cassandra, any follow-up you want to say about that?
Yeah, so I guess from an I believe you standpoint, that is really important to hear from one of your physicians, especially from just like a compassion standpoint, which I touched on earlier. And coming in just without those preconceived notions, I think is one of the biggest things, because from my perspective, as soon as you walk in the room, I can kind of tell how you're approaching the situation. And just, yeah, using that I believe you is really important to your patients and ensuring that they feel like you're actively listening and not just, I guess, dismissing any of their concerns.
Well, thank you so much. Dr. Dodick, do you have any comments on that in terms of the physician's point of view? I think you're muted.
You talking to me, Werner?
Yeah, we're just going to close off the I believe you and the importance of that from the physician point of view. Do you have any comments on people being heard?
Well, you know, it's interesting. I don't ever remember saying those words, I believe you, to a patient, because I believe actions speak louder than words. And I think patients can actually tell that you believe them. They have no doubt in their mind. If you truly believe them, when they walk out the door, they know that they believed everything you said and that you're going to do everything in your power to help that patient. And so I've never said those words because hopefully my actions have spoken for me. So, but I agree with the concept. Patients have to believe you. They have to trust you because, Kara, you made a comment earlier in the beginning of your lecture, and that is that no matter how good you are or how good you think you are, or how cutting edge you are, if your patients don't trust you, right? And then it doesn't matter. They're not going to listen to you. And then you've lost. So yeah, no, I think believe, obviously, ensure, and it's particularly true when you're discussing sensitive issues. Like if I refer one of my patients to someone like Kara for cognitive behavioral therapy or for biofeedback assisted relaxation therapy, how I frame that for the patient is really, really important, so that the patient walks out and thinks, well, he seemed to believe me, but I don't really think he does believe me, because what he just said to me, you know, if I'm paraphrasing, is that he thinks it's all in my head or all in my mind. So sometimes you really do have to couch what you say very carefully, because as you said, Kara, we've grown up with this lexicon, right? We're schooled, we're in it, and patients are coming not necessarily understanding what you're trying to tell them. So the other thing I would say is that it's really important, particularly the patients you and I see, Werner, to give them hope. You know, so what I often say is, look, I've got to list the length of my arm, the things that I can try here. So we're starting from a blank slate, and we help the vast majority of people that we see. In fact, we help everyone we see. That may not mean that we reduce your headache frequency by a day, but we can make a significant impact on your life. And when they hear that, and they also hear, and let me tell you, one of the things that patients don't like to hear is that, or one of the things they've experienced is that you've given up on them. If you throw your arms up in the air, I've tried everything. I don't have anything else to offer you. So you can't ever say that to a patient, right? You have to give them hope. And when they hear the words, look, we're never going to give up, and we're going to keep trying until we get this right, that means everything to a patient.
Thank you. Perhaps we have time for one last question, and that is, there's one that's come to us from about the traumatic headache aspect. A person is asking about post-traumatic tension type headaches versus post-traumatic cervicogenic headaches, or headaches from the neck. Also, of course, often called chronic post-whiplash headaches. And I just wanted to mention that if people have suffered a neck injury during an accident, there are specific things that can be done to try to help to diagnose that. The pain does often come from the facet joints in the back of the neck, the upper facet joints. And these can be injected with local anesthetic, and in some cases, the cause of the pain actually pinpointed. And if that can be done, then one can do ablations, radiofrequency ablations, that will relieve the pain often for long periods of time. So it's important to be aware that there are specific things that can be done for post-traumatic pain from the neck. And David, do you want to expand on that?
Yeah, I agree with what you just said, Werner. I think one of the things that we've been doing here is SPECT CT. So we do a SPECT scan and we superimpose it on a CT for spatial resolution. And what that sometimes shows you is a very hot and active facet. And if we see that, then I can send that patient down to our pain clinic, to our anesthesiologist, and they know exactly what to target, rather than doing multi-level facets and doing them on both sides, for example, because sometimes I can't tell based on examination if it's coming from a facet, what facet it's coming from. So it helps to localize the problem to a facet, and it helps localize the problem to a specific facet. So we found that to be somewhat helpful, but I agree with you. Sometimes intervening at that level can be very helpful for these patients. And maybe I'll just say one more thing, and that is that there's only really 3 phenotypes when it comes to headache. It's either migraine-like, it's tension type-like, or it's cluster-like. And it doesn't, so we tend to talk a lot about the classification, and there are 400 different causes of headache and there are 200 different headache disorders, but at the end of the day, they're either going to have a brain tumor has a phenotype of tension type headache, and a dissection of a carotid artery has a phenotype of migraine. So there are only 3 different phenotypes, and that's why I don't think post-traumatic headache, whether it has a tension type phenotype or a migraine phenotype, is either migraine or tension type headache, because you nicely pointed out in your lecture, the biology is very complex. And so I no more think that the patient with migraine after head trauma is migraine than I do think after a subarachnoid hemorrhage or meningitis, when the patient has persistent headache, that they have post-meningitis migraine or post-subarachnoid hemorrhage migraine. It's just a persistent headache due to a sensitized system that has a phenotype of migraine, but is biologically very different.
Well, thank you very much. And with that, I think we are out of time.